And we're beginning now to realize that after being on antiretroviral drugs for about a decade, HIV begins to look like a lot of other chronic diseases. There's this persistent inflammatory condition. The immune system works pretty good. It prevents AIDS, but it doesn't actually work perfectly, and there are some consequences: excess risk of heart disease, excess risk of cancer, and so forth. And so we're beginning to realize that these other diseases are becoming far more important for the treated person than AIDS. And then I'm going to take it to the next step and argue, and this becomes more speculative, that most people with HIV are young now. But as patients with HIV on therapy get older, and when I say older, I mean in their 60s and their 70s and their 80s, all these other diseases could add up to problems, and in terms of healthy aging. And now that HIV is a chronic disease, we need to switch our focus from the acute aspects of HIV infection to the chronic. And this requires a whole new set of skills, a whole new set of clinician types, and basically a different kind of healthcare system. I'm going to argue, and again, this is speculative, that many of these problems that we're dealing with, persistent inflammation, excess heart disease, overburdened healthcare systems, as well as the really big problem of not being able to afford long-term therapy, could all be addressed with a cure. And that we are now at this state where we're switching from basic science to small clinical trials, tremendous amount of excitement, a bit of optimism, that actually we are making enough progress that ultimately we'll be able to cure the disease.
Draw the parallel, if you will, in terms, if you can, in terms of where we are in that process with regards to cure. Are we in 1996? I don't think so. We're clearly not in 2013. So where are we? How long, and give some sort of sense of, you say there's some optimism. What I see is a bunch of anecdotal cases that really are going to be very hard to translate into, an atripla.
So, a great question. I think we're in 1987. So 1987 is when we were learning a bit about the pathogenesis, trying to untangle exactly what the problem is of untreated HIV infection. We're beginning to measure how much virus was there, and we're beginning to understand, we're beginning to identify potential targets to go after the virus. Okay, so that was 1987. And at that time, we developed sensitive assays to measure how much virus was there, 1 million or 100,000. Now what we're doing is trying to measure how much virus is in long-term treated people. Is it, 1 per million cells or 1 per 10 million cells, right? So it's orders of magnitude different, but it's the same question. In 1987, we were struggling with identifying targets to go after with drugs. That's what we're doing now in terms of going after the cure. And in 1987, we were beginning to look at AZT as a drug which actually wasn't going to do much. We later found out. We were optimistic. But in 1987, 1988, 1989, before my time, to be honest, we began to realize that AZT, if you gave it to a person, you affected the biology of the virus. And that's what we're doing today. We're going to hear data at this meeting that certain types of drugs, if you give it to a person on long-term therapy, you can affect the kind of virus that we need to get rid of to cure people. We're not going to cure anyone with it, but you're actually now really beginning to show that it's possible. So that would mean the triple drug therapy will be in another 8 years if we go the pathway that we did before. But you got to understand, going after the virus in 1987 is a lot easier than going after the latent virus. That was a free virus that floated around, had targets to go after. What we're going now is hidden in cells, and we're going to have to somehow get in there without causing harm to the patient, and that's a challenge.